So the technology is there. Now, as I said to you before, dying is multidimensional. It involves every aspect of who we are. So we are very good and have come a long ways from back in the 80s when all we had was liquid morphine and something called Brompton's mixture and things like that. And if people were intolerant of morphine and vomited, we were just pretty much out of luck. And now we have just multiple ways to deal with that. So it's very gratifying. However, what do we do about spiritual care? What do you do about the socio-environmental issues, the economic issues? Unfortunately, the health care system has not responded to the needs of the country in the same way that technology has responded to technological issues. You know, you could have a session with somebody on that.
Absolutely. Oh boy.
Yeah, I mean, we have a real dilemma with that. In the country. So we have people who are constantly falling through the cracks. And indeed, there is no reimbursement for palliative care at this point. There's no way to have a funded outpatient palliative care program, and just about every hospital-based palliative care program is grant supported in this country. So there is no reimbursement mechanism. Hospice is different.
Right.
Hospice has a reimbursement mechanism called the Hospice Medicare benefit. The problem with that is that it says in the law that you've got to have a diagnosis of 6 months or less to live if the disease runs its normal course. And so we do have patients who are in hospice much longer, but they have to demonstrate that they're still dying. If they get better, if they respond to a supportive environment, families coming in, being given the tools to take good care of them, having their pain and symptoms relieved, guess what? They get better. They live longer. Then we have to discharge them, you see, because they've outlived their welcome under the Medicare
6 months,
benefit.
right,
Their
right.
6 months, you know. So anyhow, that's just one of the issues that we do have to struggle with.
At the same time, at least they're not being asked to reimburse if they do get better. They're not asked to reimburse the 6 months that the federal government picked up for them. So there is some small silver lining there.
It's good,
So
and
we sure hope that folks will get better.
Absolutely, we want them, and we discharge about a third of our patients.
Is that right?
Yes.
Wow.
Yes, because they do well, and there are, you know, we do more than cancer. Some cancers stabilize and just surprise us all. But people who've had strokes, people who have bad lung disease, people who have end-stage heart disease, they are very, very difficult to prognosticate about. The person who's going to die from end-stage heart disease starts out the week they die with pretty much the same symptoms that they've had for the previous 6 months. You just don't know. There is a study of prognosis on the day before death. And they took patients and doctors in the hospital who were severely ill, and they asked the doctors each day, how much time do you think the patient has? And each day the doctor would proffer a guess. Then when the patient died, they went back and saw what the doctor said. Well, patients with end-stage heart disease were given 6 months prognosis on the day before they died. So, I mean, that's how hard. And the other end is people live much longer than you think they might, especially if you stabilize their symptoms and stabilize their environment. They really do much better. So
that is wonderful. Well, I'm thrilled to think that a third of the folks that are diagnosed with less than 6 months to live, or 6 months or less to live, incurable, that a third of those would be coming out and being discharged. That's tremendous.
Well, they have to developed the skills to live with chronic illness, and that's our challenge in palliative care, especially because then they get sick again. They come back into the hospital. The palliative care program in the hospital picks them up. And of course, our job is to stabilize them once again, but to offer them the kind of multidimensional support that allows them to cope with progressive loss, declining function, new symptoms, other losses, the economic challenges. You know, a third of people in this country exhaust their savings taking care of chronic illness.
Right, right.
So it is a very expensive proposition to be chronically ill.
Charlie, we just got about 5 minutes, and I want to pull one of the quotes you had from this piece in November 2001 or March of 2002, where you said simply, hospice began and continues in struggle, conflict, and tension. And tension, you wrote a lot about the tension component, a little about struggle and conflict. Right. In a few minutes, can you just break down, just explain that, because it's significant. You later highlighted blurring the distinction between healer and healee, which was very good, but just break down the struggle, conflict, and tension. Right.
Well, the main area in which we see that is hospice was basically the first national HMO. It's a health maintenance organization, okay? It works with a capitation fee. We get so much per day per patient, no matter how much they cost or how little. So you have that sort of framework. We are also called to this, and we are advocates of the patients, and we want everything for them they need. So we are at once both the fiscal intermediary and the provider.
Right.
So there's this constant tension. How do we stay afloat as an agency? How do we give our patients the best care they can? Do we give them radiation, which is very expensive? Do we offer them chemotherapy? You know, these are huge issues.
I hate to think that you have to go through that.
And we do that and that's why we sit down a couple of times a week and have team meetings, and then to make a decision about, okay, here's what we're going to do here, and this is what we can do, and this is what is going to work best for the patient. So I did want to tell you one story about how I got into this from the beginning.
Yeah, please, since we've just got a couple of minutes.
Yes, my father died when I was 11, and I've been trying to make sense of that ever since, and I'm sure that had something to do with it. He died at home in 1953 under an oxygen tent with around-the-clock nurses who volunteered. He was a respected physician. With doctors who came by twice a day and made house calls until he died. So I didn't get into this because my father died early and I was trying to rectify some problem in his dying. I did so because I wanted to learn how to die well. I wanted to learn how to live well until I died and to die well. And what has happened is that I have come to understand these are the most courageous people in the world. And I get up each morning and run to work because in their presence I become a student at their feet, eager to be taught.
The teacher and the student.
Reverse.
You're not the teacher there, you're clearly the student.
I've spent most of my professional life learning how to take care of people and relieve their physical symptoms, but they teach me how to die with courage and dignity and a sense of meaning.
Do you get? Do you have the sense that folks around you are feeling the same way, that they're the students? I mean, that the other professionals that are there with you, as you all have the team meetings, do you?
Yes.
You get the sense that we're all learning from each of them?
Absolutely, absolutely. It's sort of part of being in this program, and that's why it's so incredibly gratifying.
Surely blurring that distinction between healer and healee.
We bring our wounds right into that environment. That's right.
That's powerful. Well, you think there's so many different ways, and as you think about that, did you have brothers and sisters, Charlie?
I have. I had 3 older brothers. Right. One is deceased. 3 of us were physicians.
Is that right? I was going to ask if anyone else had the similar response from your father's early departure.
I think that had a major impact on all of us, yeah.
That's a powerful thing. Well, thanks so much for being with us this morning. I'm sorry we've run out of time.
That's all right.
Great to be with you. Stay tuned to a little more Carolina People. Dr. Charles Sasser, the Medical Director of Mercy Hospice, coming up next. Think about that, a medical professional for more than 40 years, knowing internal medicine, knowing patients, knowing how to deal with patients inside and out, walking into the room later this morning as the teacher and walking out as the student. Think about that, the power of that. Knowing his profession, knowing how to care for others, but walking into a room later this morning and walking out as a student. And thinking about that simple, great point from an anniversary just a few years ago where he wanted to speak. He didn't have a chance to. He later sent something back to a group to let him know what he would have said. And one of those was a simple one sentence in here. What do I do when in the midst of all my efforts to be professional, this dying person reaches out and places a healing finger on the source of my pain, thus forever blurring the distinction between healer and healee. That idea of clearly of recognizing boundaries, recognizing empathy needs to be there, but those are marked. There's a lot that goes into it. There's a lot of distinctions that need to be clear. Dr. Sasser will be doing it later this morning. He'll be doing it this afternoon. He'll be doing it later, even into the evening. He's doing it every day and making a difference. Dr. Charles Sasser, thanks so much for being with us this morning.
My pleasure.
Absolutely. I'm sure you can.